it's always best we should also have some inclination to what pathologist is talking about, so that we can criticize them when they are wrong, or we criticize ourselves that when we went wrong. So the best is to appreciate what an histopathology slide has been spoken and written about, so that we can conclusively make it. That was one of the attempts we have tried to do. This particular case is one thing where I really went into trouble. I mean, I can just try to put it across. This is with reference to our previous talks and lectures, how difficult it is sometimes to work on tuberculosis and autoimmune disease. This patient, Mr. S, is a 28-year-old software engineer who was referred to me from a neurologist for a second opinion and further management. His basic presentation was fever since 1.5 months, diplopia from last 1 month, excruciating headache, which is not easily relieved by any of the analgesics and NSAIDs. MRI showed multiple ring-enhancing lesion in both cerebral and cerebellar areas. Hemoglobin was 12.8 with a total count of 10,500 and ESR being around 70 millimeter. The referral note further said that OTPT were high, it was 62 and 60 with other liver functions normal. CSF showed an elevated protein of 441.2 milligram, cell counts of 70, predominantly of lymphocytes with ADA 36. Anti-toxo IgG in CSF was positive. The Mycobacterium tuberculosis immune complex was positive. Patient's anti-HSV antibody in CSF was negative. Serum uric acid was 7.8. Diagnosed as tuberculosis, treated with 4-drug anti-tuberculosis for first 15 days. Not much of response. He added streptomycin for 1.5 months, and few other antibiotics were also added. Patient continued to have fever, continued to have headache, no fresh neurological deficit developed other than diplopia. At this point, patient was referred thinking a second alternative possibility, it could be an isolated CNS vasculitis or some other probable autoimmune disease. When I examined, patient was still febrile and neck stiffness was present. There was no neurological deficit except a minimum lateral lag in either side's eye movements. Not really, there was a lateral rectus palsy, but there was minimum lag in the lateral eye movement. Anti-nuclear antibody was negative, ANCA was negative, complement level was 129, CRP was 8.73. I was trying to tell you in my lecture, probably if this is the case, it may not be the infection. So look at the problem. The problem was CSF was showing Mycobacterial tubercular positive for immunoglobulin, but we always take it that if CSF has a positive response, try to reconsider a possibility of tuberculosis. Tentatively, what I did was, I diagnosed it as an isolated CNS vasculitis, started the patient on azaran, gradually to increase from 25 milligram, continued ethambutol, discontinued others since SGOTPT and other enzymes were abnormal, and also continued streptomycin for subsequent second week, and put him on steroids of around 1 milligram per kg body weight, and clinical status remained same for the subsequent 2 weeks. Patient's fever didn't come down, continued to have headache, continued to have diplopia. So I thought treatment may be insufficient. The next proposal I took was patient was admitted with his ESR being 70, OTPT being still higher. So I this time took a dare decision that let me not go ahead with any of the tubercular treatment and pulled out because it's almost 2.5 months of anti-tubercular drugs. I went ahead with IV methylprednisolone of 1 gram every day for 3 days and followed by 1 milligram per kg body weight of prednisolone and added azathioprine and continued to treat him with azathioprine. Patient significantly improved symptomatically. Headache gone, fever settled, diplopia disappeared, and patient developed little of oral candidiasis. I started him on fluconazole and candidiasis improved, and the count started dropping to 3,450 by the end of second month with azathioprine. That prompted me to withdraw azathioprine and put him on to mycophenolate meftil and went on going gradually reducing his steroids. Grams The patient was brought into the outpatient clinic in an emergency. At this point of time, patient had a severe headache, but he didn't have diplopia. He had a high-grade fever, no neck rigidity, vitals are stable, but patient was confused but conscious. Admitted to ICU, continued to steroid and stepped up the steroid. Probably I thought since the steroid was dropped down, possibility that the patient might have flared his vasculitis. Antibiotic was added, ceftazidime and amikacin, with probable diagnosis of viral infection worsening with the disconfusion and other status. At that time, hemoglobin was 12 grams, ESR was just 35, C3 was 145 and CRP was 24 milligram. We thought that 24 milligram could be because of viral infections. Other parameters, metabolic, liver functions and creatines are normal, trying to explain the altered sensorium. We planned to do CSF, but in the second day, patient improved with the increase of steroids. So we thought probably it could be just a vasculitis flare because of viral infections, and we continued further. But on the third day of admission, patient again complained of excruciating headache and became unconscious. This was a call from the wards, from the duty resident saying that the patient is unconscious, rush immediately. So at this point of time, I decided I think probably we are missing something. Let's go ahead with LP. Lumbar puncture was done. CSF showed a protein of 100 milligram, cell counts of 100, predominantly lymphocyte. Now what? Where am I? At the same time, I asked for CSF to be sent for tubercular PCR. Started tentatively on 4-drug ATT because I'm now not very sure whether I'm handling tuberculosis or handling vasculitis. We continued with, as I said, steroid, immunosuppressives, anti-tubercular and antibiotic at this point of time. With anti-cerebral edema measures, by 6th day of admissions, it's the 6th day of admission, 3rd day of ATT, patient's sensorium started improving, became conscious, little coherent. Now I'm confused. Now what's happening? What am I really dealing with? Is it a vasculitis? Is it a tuberculosis which I so far managed with the immunosuppressives? What was the next issue that I was handling at this point of time? Considering this, could it be tuberculosis worsened by the immunosuppressives? I started reducing steroid gradually from 120 milligram to 80 milligram to 60 milligrams, stopped MMF, mycophenolate meftil, and slowly replaced steroid with dexamethasone, basically because dexamethasone in addition has an anti-cerebral edema effect. On the 11th day, with ATT, with the withdrawal of steroids to 60 milligrams, patient started developing fever, headache, diplopia and paraparesis. Tapering of steroid was held back for a day, followed by escalation of dose of steroids. On the very next day, I scaled up the steroid once again to 120 milligram per day with mycophenolate. By 30th day with ATT and the 10th day of increased dose of steroids to 120 milligram per day, patient symptom improved, patient was stabilized, both the leg power improved, only residual defect happened was his bladder control continued to be abnormal. He couldn't control his bladder retention continued, otherwise patient significantly improved at this point of time. Then I attempted for a discharge before discharging with the catheter probably because it's almost 1.5 months in 1 month of stay. At that time when we tried to switch over to oral steroid from 120 milligram, we tried to reduce to 60, 70 milligrams up to 80 milligram, patient symptoms started relapsing. The moment I cut down the steroids, patient symptom used to relapse back. Patient used to develop headache, fever and diplopia. The follow-up MRI showed a small lacunar infarct. This is on the 42nd day before a week before discharge. If we could find that MRI showed a small lacunar infarct at cardiac nucleus on the right side, otherwise it was not remarkable. In a sense, those ring shadows, all those shadows had totally disappeared. The patient was put on MMF, ATT and a steroid of 80 milligram was per day. At this time patient was stable except for the bladder abnormality and was discharged. So in a sense he had recovered almost with a neurodeficit except the bladder control. He was afebrile and was stable at the point of discharge. So in a nutshell, see, if you look back into this, we encounter a difficulty in making a right diagnosis. When we are still not sure whether the first episode was it a tuberculosis and a vasculitis, or was it only a vasculitis. I mean, looking at the way the course of events has happened, probable explanation I could put is that it could have been a vasculitis the first event, the TBM the second event, and it was in the end of the day patient developed both vasculitis and tubercular meningitis, from which the patient has been treated. Any comment from the chair as well as from the other speakers?
What is the next follow-up, sir?
He has been discharged a week before.
Cases which were seen in CT scan are not seen in MRI scan. That means they are disappeared.
No, the ring enhancement was seen 4 months before, the first visit with the neurologist when MRI was done. In the second visit in admission, when he came in emergency 4 months later, what we did was only CT. CT was normal, so we didn't go ahead further with MRI or any other imaging modality. Because 4 months of exhaustion, each investigation we were thinking twice before we seek for it actually, because the cost factor was one of the major crux for me in asking for any more tests.
They have to be on an ATT plus.
There is no demyelination.
Post year.
MRI, second MRI also didn't show demyelination, it was more a lacunar infarct. The first MRI had the ring enhancing lesion. The last MRI was only showed a small lacunar infarct, because by then he didn't have any neurodeficit too when we sent for it.
We'd be interested to know what type of vasculitis you are thinking. Was it like Wegener's or Neurobesche?
It is what we call as isolated CNS vasculitis, where CNS vasculature is alone the target.
Ring enhancing lesions, what provisionally could have been Wegener's, differential diagnosis as well, Neurobesche possibility.
These are the possibilities, because to call it as a Behçet, call it as a Wegener's, we need other more criteria to call it. Since it's fairly located only in the CNS, no other systemic features, we just call it as isolated CNS vasculitis, still if it shows something else for a period of time.